This is the first webinar of our Hard Times for Harm Reduction series. Watch for the second one that will happen on February 24th and will be related to prison. Je m'appelle Cécile Kazachkine, j'ai la chance de travailler au réseau juridique VIH et beaucoup d'entre vous depuis longtemps. Le réseau juridique VIH, c'est une organisation de défense des droits humains. Nous défendons les droits des personnes qui vivent avec le VIH et qui sont affectées par le VIH, les lois punitives et la criminalisation au Canada et dans le monde. We are delighted to have both French and English-speaking speakers and attendees today. Please note that there is simultaneous interpretation and look at the icon for interpretation and please pick your language of preference. Pour celles et ceux qui nous rejoignent, sachez qu'il y a une traduction simultanée qui est disponible, donc n'hésitez surtout pas à l'utiliser en choisissant votre langue de préférence, anglais ou français. And please also note that the webinar is being recorded. Before we start, I'd like to offer some land legacy of anti-Black racism and JIPA-MIPA acknowledgements. Today, most of us are coming together on this virtual platform from across Turtle Island, the lands and unceded territories of many different indigenous groups and communities who have respected and cared for this land since time immemorial. As people committed to addressing ongoing injustices and health inequities, we must recognize that many of these harms are the result of the history of colonization and its ongoing impacts. We must acknowledge the legacy of anti-Black racism and its relationship to criminalization and punitive laws and practices, including on the issue on which we work. We recommit together, whenever we come together, to working towards a more just future for all that respect Indigenous people and Indigenous ways of knowing and being and combat all forms of racism. We must also acknowledge that the greater involvement and meaningful engagement of people living with HIV and people with lived and living experience is central to any successes in the fight against HIV and for human rights. Today, in particular, we want to pay tribute to all the people who use drugs in Canada that have been killed and harmed by the toxic drug crisis, punitive laws and policy, and everyone who have lost loved ones. I hope we leave today's event with a sense of renewed solidarity and collective commitment to end punitive laws that continue to unnecessarily harm and kill our communities and unjustly deprive so many of vital access to care. So before we start, just some necessary housekeeping. We have, next slide, please. We have 1 hour and a half for the webinar without a break. So following my quick introduction, we'll hear 2 presentations. The presentation will be followed by a group discussion that will be moderated by our dear Bita Senejani from the Canadian Drug Policy Coalition and involving 4 panelists from Quebec, Ontario, and BC. And after that, we'll have time for Q&A after the group discussion. During the webinar, you will be able to ask your question in the Q&A chat box. Please remember again that there is simultaneous interpretation. So please n'hésitez pas à utiliser la traduction si vous avez besoin de traduction. Et aussi que le webinar est enregistré. I think I said everything in terms of housekeeping, so we can dive into the issue. We are all meeting today to discuss access to supervised consumption services in Canada. We are going through quite overwhelming times with a relentless toxic drug crisis that continues to kill an average of 17 people in Canada per day and multiple attacks against harm reduction, people who use drugs, and those who are working with them. And instead of seeing support, we're seeing more legal and policy barriers undermining access to life-saving services at all levels of government. Thankfully, there is also resistance, and I hope that we can discuss collective mobilization today to push back and safeguard access to these services. Next slides. So just to make sure that everyone is on the same page, supervised consumption services are evidence-based health services that provide a safe, hygienic environment where people can use drugs under the supervision of trained staff or volunteers. The terminology used in Canada to name supervised consumption services can varies depending on where they are located, how they are operating. So you may hear supervised consumption sites or overdose prevention sites or UPHNS, which are urgent public health needs sites. So those varies, but those are all the same concept of supervised consumption services. So this is that will be the common name that we use here. Next slide, please. And I'm not going to go into detail in terms of the legal framework that surrounds SES in Canada and all the nuances around exemption. But I just wanted you to remember that SES are different from other harm reduction services in Canada because they generally require a federal exemption to operate safely, because otherwise staff or client could be at risk of prosecution in relation to possession or trafficking that are prohibited in Canada. So it's Health Canada, the federal government, that is the entity that grants exemption to SES providers, and they generally do so on a case-by-case basis. For BC, it's a bit different because OPS, the overdose prevention sites, they can operate without a federal exemption. I'm not going to get into the details, but just for you to know. And really, sites have proliferated there. Next slide. So you can see that really SES engaged all levels of government because you need an exemption at the federal level to operate, but then it's usually the provincial government that is responsible for funding the sites. And unfortunately, in recent years, we've seen some local government hostile to harm reduction increasingly creating barriers to SES through provincial legislation that limits the establishment of SES and also through funding cuts. So compared to other countries in the world, Canada has many SES operating, but there is immense disparity in access across the country. And as I just said, after a few years of promising expansion, we are really experiencing a serious crisis with many sites being forced to close down, many sites that cannot operate because they have no funding or that are not allowed to adapt their services to evolving modes of drug consumption. We'll talk about that. And that cause the causes of drug-related deaths. And to give example, in Alberta and Ontario in particular, we are really witnessing the dismantlement of SES with many sites closing one by one. But our speakers will talk more about this and in a better way than me, and I'm very pleased to introduce them today. I'll introduce our first speakers who will be doing a presentation, Gillian Kola and Sandra Karanchu. So Gillian Kola is an assistant professor in population health and applied health sciences at the Faculty of Medicine in Memorial University of Newfoundland. And Gillian is studying the impact of the closure of SES in Ontario, and she will share with us some of the results of her study that will shed the light on why it is so essential that we mobilize to safeguard these services. And Sandra Karanchu is my dear colleague at the HIV Legal Network. She's the co-ED, and she's deeply engaged in drug policy and prisoners' rights. And Sandra, she will discuss how we are trying to stop this hemorrhage by fighting back in courts. So now I'm passing it to Gillian, and welcome to the webinar.
Thank you so much, Cecile, for having me. And thank you all for hosting this very important topic today. So next slide, please. I'm going to start today by giving a brief overview of some of the research that we've been doing on the ground in Ontario, monitoring the impacts of the changes to supervised consumption site provision in the province. But before we get started and talk about the results of what we're seeing so far, I just want to clarify two really important aspects of the legislation passed very rapidly in December of 2024 by the Ontario government, the Community Care and Recovery Act. Now, this has received a lot of attention because there was a prohibition in this legislation on operating a supervised consumption site within 200 meters of a school or childcare facility. As a public health researcher, this is very concerning because this legislation doesn't consider evidence on need for supervised consumption sites in a community or on the ways in which urban areas frequently have delivery of many different kinds of essential health, social, and educational services in close proximity to each other, just due to the density inherent in urban settings. Instead, this legislation relies on stigmatizing certain evidence-based health services because they center harm reduction approaches, with the result to remove essential healthcare from communities. And this is in fact what we've seen. Since the legislation was introduced, there have been 9 supervised consumption sites that closed, including 4 in Toronto, 1 in Ottawa, Hamilton, Kitchener, Guelph, and in Thunder Bay. And I think it's important to note that due to closures of sites that had been operating previously in Sudbury and Timmins, which are in the northern part of Ontario, along with Thunder Bay, after the provincial government refused to fund them, there's now no sites operating anywhere in northern Ontario, which is a region home to 80% of all First Nations communities in the province, and with an overdose mortality rate that's double the southern parts of the province. There's one of these supervised consumption sites that was caught within the 200-meter rule that's still operating after receiving an injunction. And Sandra's going to tell you a little bit more about that in a second. Interestingly, the organization that is still open and operating also operates a childcare facility that's within 200 meters of their supervised consumption site. And they've continuously highlighted how both are crucial community services, which can and do operate close to each other. Next slide, please. So while the 200-meter rule has received a lot of attention, there's another aspect of the Community Care and Recovery Act that I think is really concerning, namely a limit on the powers of municipalities and local boards of health to apply to Health Canada for exemptions to operate supervised consumption sites, or in our case, to renew exemptions for existing supervised consumption sites. So Ottawa Public Health site that they operated in downtown Ottawa was forced to close due to this provision. They actually did request from the province permission to keep operating and were refused. And this has also led to the closure of 4 sites in shelters in Toronto, where the need for those sites was very, very great. Additionally to this, there's also been 1 supervised consumption site in the West End of Toronto forced to close after the government of Ontario pulled their operating funds, but that wasn't actually wasn't captured in the larger Community Care and Recovery Act. So I just wanted to highlight the 3 different measures that are currently in place and being used by the Ontario government to force the closure of sites. Next slide. So as a public health researcher who's very aware, I've been doing research around harm reduction approaches to the care of people who use drugs for a long time, and I was really aware of the strong evidence base on how supervised consumption sites reduce overdose mortality and more broadly support the health of people who use drugs. And so we quickly moved into the field in January of 2025 in order to start conducting some in-depth research to monitor the potential impacts of closures of these sites. So we managed to actually interview 104 clients and service providers in 5 harm reduction programs in 4 cities prior to the closure of sites to get baseline data before the closures occurred. And since April of 2025, we've actually been interviewing in 7 programs across 5 cities. This is research that's continuing to this day so that we can touch on every region of Ontario that's been impacted. And we've spoken to over 100 clients and service providers in organizations offering harm reduction services or that used to offer supervised consumption sites, and people who used to access supervised consumption sites. And so just to share some of our results so far, next slide, please. Very unfortunately, our results are very concerning, considering the changes that are happening in the community. The first is around increases in overdose risk, overdose occurrence, and public drug use. Now, if you look at the first quote on this slide, it's from a client who captures the difficulty in closing sites where people who are still afraid of overdosing now try to use drugs in public bathrooms of places that used to operate supervised consumption sites after the site was closed, or in public washrooms close to former sites, which is things that we're hearing a lot about. Now, this puts a huge amount of pressure to be intervening in overdoses in very difficult situations. Staff will frequently talk about how difficult it is to intervene in a bathroom stall versus in a controlled environment of a supervised consumption site where everybody is primed and ready to intervene. Next slide, please. We're also hearing about significant increases in both public drug use and use in hidden spaces following the closure of sites, as well as increased overdose-related deaths. Now, this seems to be primarily driven by people who used to use in supervised consumption sites being forced to move into unsupervised areas, so using outdoors in parks and alleyways, in public washrooms, parking lots, and other hidden areas following the closure of sites. I know this is dangerous, not just because, as we've already talked about, that means there's no one available to intervene quickly if an overdose occurs, but this also causes increased pressure on paramedics, which we've actually seen in several communities where supervised consumption sites closed following those closures. And we are very sadly also hearing about increases in deaths following closures of sites, particularly among clients who were using those sites frequently prior to their closure. This is leading to tremendous amounts of frustration from both clients and staff who attempted to caution the government that closing supervised consumption sites would not have an impact on public drug use and would in fact make that worse, and that this would result in overdose-related deaths. Next slide, please. We've also seen really significant impacts on the availability of low barrier health and social services. And I think one of the points that was very underappreciated about supervised consumption sites in the broader public was the way in which they functioned as low barrier health and social service connection points, as well as places where people would go to access primary care and wound care from nurses that were on site, as well as specialized healthcare services. Now, taking away these supervised consumption sites takes away a very low barrier access point to the healthcare service, to the healthcare system, and actually increases burden on other parts of the healthcare system, particularly primary care and emergency departments. Next slide, please. We've also heard a lot from clients about the impacts of losing a community-based space. And interestingly, one of our findings is actually a significant increase in police presence, police enforcement, and arrests around sites. And clients often actually describe this as happening almost one day to the next after sites close, where in the immediate vicinity of supervised consumption sites, police are very, very present after site closures where they hadn't been before and are starting to arrest people much more. Next slide. Staff also noticed this increase in policing and in crackdowns on public drug use. And in their attempts to talk with police about this, some will tell you that they're not actually jailing people or charging them, that it's just actually an attempt at displacement and to try to deter people from being around the sites. And again, I think especially given the findings we have around the difficulties of overdoses in hidden spaces, this is very, very dangerous from a public health point of view in terms of the way in which criminalization and policing may be driving people into hiding and into hidden areas to use, which increase their risk of overdose mortality should an overdose occur. Next slide, please. Next slide, please. I'm hearing a lot about an extreme disillusionment from both clients and staff about the loss of these critical healthcare services. And I think that one of the things that's really, really important to recognize is that people who use drugs experience significant stigma and discrimination when trying to access the larger health and social service system. So losing the space that was adapted and specialized to their needs is particularly dangerous. Right now in Ontario, we're having a very, very difficult and cold winter. We're hearing a lot about reports of frostbite and difficulties of staying warm among people experiencing homelessness. And I think that staff as well, in addition to the really strong moral distress that they felt as services were closing, they reflected on how changes to the supervised consumption site model to move to the heart hubs didn't seem like they were being set up in a way that they were being aimed to succeed or designed to succeed. In fact, they would describe the rollout of the Heart Hub model, which replaced the supervised consumption sites in many areas, as being characterized by a lack of consultation, a lack of transparency and clarity from the province on elements of the new service model, as well as strong difficulties around transitions to new funding. And this led to concern that in addition to closing life-saving services that were meeting a really crucial need for clients, the changes that were being put in place in the province were a mere window dressing that would not lead to real structural changes that are needed to actually address problems associated with homelessness or the drivers of substance use in our communities, and would instead make the situation worse. So that was a very, very quick look. Next slide, please, at what we are beginning to see in Ontario. We have received funding in order to be able to continue this research from the Canadian Institutes of Health Research. And so we're going to be able to continue to monitor the patterns of changes that we're seeing on the ground over the next few years. And my email address is there in case anybody wants to get in touch and speak more about the research that we have undertaken. And now I'm going to turn this over to Sandra Cajon-Chu from the HIV Legal Network.
Thank you so much, Jillian, and thank you for undertaking all that research, which is really critical in court cases, as we know, which I'm going to touch on. And there's a lot of cases happening across the country right now. I describe it as a legal assault on harm reduction services in this country, but I'm only going to focus on two case studies that I think could really shape the harm reduction landscape and supervised consumption services in particular in this country. So first, I'll touch on the Community Care and Recovery Act, which Jillian already mentioned. She already said there's two major aspects of this related to supervised consumption services specifically. The 200-meter rule, can't operate within 200 meters of a school or childcare center, and the requirement for municipal approval. And this is on top of the barriers that we supervised consumption sites in Ontario already face with respect to funding. And you also heard from Jillian how sites, before this legislation even came to pass in December, were getting defunded or not funded at all and were forced to shut their doors. Next slide, please. Oh, sorry, stay on the slide. So when the CCRA was introduced, I'll just use that for shorthand, the province was funding 17, what we call in Ontario, consumption and treatment services in Ontario. And the 200-meter rule would affect at least 10 sites in the province. As Jillian mentioned, 5 in Toronto and 1 each in Kitchener, Hamilton, Guelph, Thunder Bay, and Ottawa. Other sites would be impacted because of the municipal prohibition. And we know when the law was passed, our health minister, Sylvia Jones, was clear, quote, there will be no further approvals of consumption sites in the province of Ontario under this government. What I think is especially disturbing is when the law was passed, there was a media leak. Somebody found out there was government advice given to the Ontario government from their lawyers. And what they warned them was that the prohibition of supervised consumption services within 200 meters of a school or childcare center created a, quote, high risk of infringing the charter. So they knew that this was potentially a constitutionally uncompliant piece of legislation, but they passed it anyway, and they raced it through the Legislative Assembly without opportunity for much debate. So what happened next? We had some amazing advocates step up. The Neighborhood Group Community Services, which is a social agency that operates downtown Toronto, a supervised consumption site called the Kensington Market Overdose Prevention Site, or KMOPS for short. Catherine Resendez and Jean-Pierre Aubry-Forges, two individuals who access supervised consumption sites in Toronto and Kitchener, challenged the law in court. Within, I think, less than a week of the law's passage, they initiated the charter challenge. What they asked was the Ontario Superior Court of Justice to rule that the legislation violates our charter, the Canadian Charter of Rights and Freedoms, or in the alternative that is otherwise unconstitutional because it is infringing on the Health Canada, federal government power to authorize these sites. So they argued two major charter violations. They argued that the CCRA violates Section 7 of the charter, which guarantees the right to life, liberty, and security of the person. They said by closing the sites, the legislation unlawfully violates the rights of those who access the supervised consumption site by, 1, increasing the risk of death by overdose, 2, forcing people to resort to, quote, unhealthy and unsafe consumption where there's a significant risk of morbidity or death, 3, forcing people to consume outside the sites and exposing them to a higher risk of criminalization, and 4, exposing them to a higher risk of infectious disease and other harms to their health. I think it's really interesting that Gillian's research has already been bearing this out. All these things that the lawyers and the applicants here predicted would happen is being borne out in the research. They also argued that the legislation violates Section 15 of the Charter, which guarantees the right to everyone to be free from discrimination. According to the applicants, the law imposes disproportionate burdens on those experiencing, quote, substance use disorder, which is recognized as a disability in law that's prohibited ground for discrimination, but by depriving them of the services they need and reinforcing stigma. These disadvantages are even more pronounced for those who are women, homeless, Indigenous, or are otherwise racialized, or have other mental health and physical disabilities. Several organizations, including the HIV Legal Network, together with the HIV and AIDS Legal Clinic of Ontario, intervened before the court in support of the challenge. The issue of provincial funding, unfortunately, was not before the court. So the case was heard in March 2025, over a few days, and the court was packed with activists, journalists, lawyers, and other people who care about the site. And while it was really frustrating to hear the government lawyers minimize the benefits of supervised consumption sites, it was a beautiful moment of community mobilization. Shortly after the hearing on March 28, 2025, the court ordered an injunction exempting all existing sites from the provision of the law that the 200-meter rule. So the judge in this case said, the 200-meter rule does not apply until 30 days after my final decision, my decision on the merits. And the court granted the injunction on the grounds that the closure and resulting increased risk of unsupervised drug use risks irreparable harm. And I'm just going to read a finding from the court. The judge said, it is foreseeable that many more will overdose and some of those will die. Death and disease that would have been prevented will now not be prevented because those who would have used a site will now consume drugs in less safe settings. The other health and social services provided by sites and for which sites are a gateway will no longer be accessed at the same rate. Given the number of users that are affected by substance use disorder, homelessness, and other marginalized characteristics, the impact will be felt by the most vulnerable. Now, this was a great moment of victory in some ways, but despite this recognition, the injunction does not cover the prohibition on municipalities, the rule that municipalities have to ask for the province's approval in order to operate. As a result, sites in Toronto, Peel, Ottawa, and in Kitchener that were supported by municipalities have been forced to close. Further, the injunction has no impact on Ontario's denial of funding to all sites. Without this funding, most sites will be unable to sustain their vital work, even if technically permitted to operate. And we know that most sites affected by the 200-meter rule did shut down. To maintain funding, many of them opted to convert to the heart hubs that Gillian mentioned before. These are recovery-oriented services funded by the province, which explicitly forbid supervised consumption sites and needle and syringe distribution if they want to maintain the heart hub funding. TNG and KMOPS was one of the sites able to keep its doors open because of the injunction and because they do not depend on the province or municipality for funding. So it's been some time now. This decision is expected any day now, and I think it will be another important moment to support the applicants and for community mobilization and solidarity. We also know that sites continue to be at risk of provincial defunding, like we know from a site in downtown Toronto, the West End, and because schools or childcare centers that open within 200 meters of the site, even if they open after the site has been established, could force the site to shut down. And that's a situation we're seeing right now in St. Catharines. Janet's going to put a link in the chat with an article about how a potential Montessori school within 90 meters of the St. Catharines site could affect its operation. Next slide, please. And now I'm going to move to the second case study, which is about a case in Alberta, the Brown versus Alberta case that was just decided last summer. And in this case, it involves, in September 2024, we know that there's been an assault on harm reduction services in Alberta for some years, but earlier in the fall of 2024, the government announced it would close Red Deer's overdose prevention site, citing a Red Deer Council resolution requesting that the OPS be closed. Instead, Alberta said it would, quote, implement options focused on health, wellness, and recovery, and fund new services in Red Deer, which, as we know, cannot replace what supervised consumption sites do. So in response, Aaron Brown, who was a client of the Red Deer OPS from the time it opened in 2018, decided to challenge this decision. He argued that the closure of the site would affect his charter rights, Section 7, 12, which is the right to be free from cruel, unusual treatment and punishment, and 15, which is the right to be free from discrimination. I'm going to quote Aaron Brown here. He said, "I would be dead without the Red Dare OPS and the supervised consumption services it offers. I would likely acquire other diseases and infections through street-sourced opioid use and be hospitalized and lose the social and economic supports that I have, including housing. It is terrifying to imagine what my life will become once the Red Dare OPS closes." So before the hearing of the merits, Mr. Brown and his counsel sought an injunction, which is like to prevent something from happening, to prevent the site from reducing its opening hours, which was the first step the Alberta government proposed, like reduce the opening hours. And they got that. They got that last January. And then they sought another injunction to continue to force Alberta to continue funding and operating the OPS past its scheduled closing date, which is the end of March 2025. That was not successful. So the OPS ultimately closed on March 31st, 2025, when its provincial funding agreement ended. Following that, the hearing of the merits was in June 2025, and a decision was released last August. In its decision, the court dismissed Aaron Brown's claims. Among the reasons the court offered for dismissing the charter claims, it concluded that the risks to Mr. Brown's life and health are not solely because of the shutdown of the OPS. What the court said was, Mr. Brown's risk arises from, among other things, the underlying substance use disorder, the potency of street drugs, and the commitment of the affected user to access services. It does not arise solely from Alberta's decision to reallocate funding to recovery-based alternatives. This is despite the fact that numerous higher courts have said that breaches of the security of the person or charter rights need not result from only one cause. The court also repeatedly referenced treatment services that Alberta is funding, including the narcotic transition service that Aaron Brown had enrolled in, and minimized the harms of the OPS and Mr. Brown, despite the fact that Aaron told them, the court, how it did not treat the NTS, did not treat a stimulant use, had very limited capacity, and he ultimately overdosed after the OPS closed during the evening when the NTS service was not available. The court also stressed that there is no, quote, constitutional right requiring the government to continue offering health services even if they're life-saving. And we know courts in Canada have historically been reluctant to find that a government has a positive obligation to fund services to ensure access to care. Now, the decision is being appealed and a hearing will occur in May. Some organizations, including the HIV Legal Network and CDPC, are discussing a potential intervention. And so we hope that will be another opportunity for mobilization. Before I wrap up, I just wanted to say that provincial attacks are not the only legal assault on supervised consumption services in this country. In Ottawa, for example, we know that an individual business owner is challenging the renewal by Health Canada of Ottawa's inner city health SCS exemption that was granted last fall. This individual claims that there was insufficient community engagement and cited, quote, significant negative impacts in the neighborhood that are associated with the site, including crime, vandalism, public drug use, overdose, etc. These claims are obviously very concerning because they could impact Health Canada practices around exemptions, and we already know Health Canada is asking for more from SCS applicants. We know people are also suing services for people who use drugs and blaming them for these alleged, quote, negative impacts. Sanctuary Ministries, a church in downtown Toronto, for example, is subject to a $2.3 million lawsuit from a neighboring condo board, which claims sanctuaries permitted, quote, illegal, illicit, disruptive, interfering, and egregious conduct. So this is all part of a narrative, an emboldened movement against people who use drugs with the aim to ultimately wipe out harm reduction services, which people who use drugs have fought so hard to establish. Thankfully, our next panel, we will feature some advocates who are mobilizing and pushing back, and our next speakers will be describing some of these initiatives. And I'll pass it over to our dear colleague Bita at CDPC, who will introduce the panel. Thank you.
Thank you so much, Sandra, and thank you to the Legal Network for hosting this important conversation. It's a privilege to be on this panel with you all, given all the incredible work that you're doing. My name is Bita. I'm with the Canadian Drug Policy Coalition, and we'll just get right into things, bringing our panelists on to the screen. And to begin our panel, I'd like to introduce Sandhya Vadlamudi. Sandhya is the Executive Director of l'Association des Intervenants en Dépendance du Québec, AIDQ. Sandhya works within the Harm Reduction and Substance Use Network at the provincial, national, and international levels by sharing expertise, developing knowledge, and engaging in political and social activism. And previously, Sandhya served as the Executive Director of Cactus Montreal, a leading organization in harm reduction, where she launched the organization's Supervised Consumption Service in 2017 after 10 years of advocacy. Thank you, Sandhya, for joining us today. Sandhya, we heard new legislation limiting supervised consumption site establishment in Quebec was enacted in November 2025. We understand that the legislation is less restrictive than the one in Ontario, but does impose some requirements regarding minimum distance from schools and daycares and ministerial approval for some sites. Do you think this legislation reflects a shift in Quebec's approach to supervised consumption services or a national trend? And how did civil society react to the introduction of the legislation? And what are the results and lessons learned?
Merci, Bita, de me passer la parole. Merci aussi au réseau VIH pour l'invitation. Et je suis très heureuse de pouvoir m'exprimer en français aujourd'hui. J'essaierai de parler doucement pour la traduction. Alors, malheureusement, oui, Bita, cette loi est le reflet d'un certain changement d'approche au Québec. Elle est en fait une conséquence directe là, du vent de droite conservateur qui souffle un peu partout au pays et le Québec en fait pas exception. Les politiques qui sont basées sur les droits, notamment celui à la santé et les données probantes, sont en recul partout et on en a les conséquences également chez nous au Québec. Le Québec, traditionnellement, a quand même endossé fortement l'approche de réduction des méfaits depuis de nombreuses années, mais en utilisant ce véhicule-là législatif pour restreindre les services de consommation supervisés, le Québec, en quelque sorte, désavoue ses propres politiques. C'est une réponse qu'on peut se dire populiste, une réponse de courte vue qui crée des dommages beaucoup plus que de bienfaits. Alors, à l'annonce, en fait, du dépôt du projet de loi, ben, ça n'a pas été très long que la société civile s'est organisée. En fait, on avait déjà fait quelques démarches au préalable, mais rapidement, sous un certain leadership de l'Association des intervenants en dépendance du Québec, il y a 30 organismes et regroupements québécois qui se sont coalisés pour demander le retrait de ce projet de loi à travers des communiqués de presse, à travers des représentations médiatiques. Donc, à partir du projet de loi, on a identifié tous les éléments là, qui étaient problématiques et pour lesquels on voulait et desquels on voulait créer co-construire un mémoire. Alors, ensemble, on a déposé ce mémoire et on a fait plusieurs actions en termes de relations gouvernementales. On a rencontré le ministre, rencontré l'ensemble des oppositions pour faire valoir nos messages clés et faire grandir l'appui pour qu'on arrive à être invités aux consultations parlementaires. Donc, cette invitation, on l'a reçue, mais on l'a reçue sous l'égide de la IDQ seulement. La IDQ a donc choisi d'utiliser cette opportunité-là de façon encore là collective en invitant des groupes pour prendre parole au même titre que la IDQ lors des représentations à la commission parlementaire. Donc, on a eu un groupe porteur d'un SCS, un groupe représentant des personnes qui font usage de drogue et un groupe qui œuvre en santé et réduction des méfaits. Et on a tous ensemble là, utilisé ce moment pour faire valoir nos messages clés pour contrer la désinformation et sensibiliser aussi à l'importance de la réduction des méfaits en tant que solution. Et ça, on l'a fait aussi suite à ces consultations-là. On a continué cette mobilisation-là et notamment, on l'a fait à travers une lettre ouverte pour laquelle on avait recueilli près de 300 signatures, dont plus de 150 qui sont issues d'organismes et de regroupements pour mettre de l'avant l'importance, en fait, des services de consommation supervisée et le fait que cette loi-là était complètement inacceptable. Cette lettre-là a quand même apparu dans un média important au Québec et elle a quand même contribué là, à faire une pression politique et on a pu utiliser cette publication-là pour poursuivre nos représentations auprès du ministre, auprès de l'ensemble des oppositions, avant d'arriver à l'étude détaillée qui est la dernière étape avant l'adoption de la loi pour pouvoir encore réaffirmer comme coalition notre position, c'est-à-dire complètement contre ce projet de loi. Mais en même temps, la machine était en marche et on voyait l'adoption de la loi arriver bientôt quand même. Alors, on a fait tout un travail sur des amendements parce qu'on voulait quand même, dans ce contexte-là, assurer la pérennité des SCS et assurer et également l'accessibilité à ces services pour les personnes qui en ont besoin. Donc, par exemple, on demandait d'avoir une clause grand-père pour les services qui étaient déjà existants et qui contrevenaient à ce projet de loi-là en ayant moins de 50 mètres de distance là, avec les garderies ou une école primaire. Donc, toutes ces étapes-là, on les a fait de façon très rapprochée, très solidaire, en l'espace d'environ 6 mois. Et en bout de compte, la loi a été adoptée. Donc, bien sûr, la coalition n'est pas heureuse de cette situation, mais on peut quand même regarder le travail de collaboration comme un résultat en fait positif, puisqu'on a réussi à faire disparaître et modifier des articles qui étaient très problématiques dans le projet de loi. Alors, à ce jour, la loi reflète à peu près 80 de nos demandes d'amendement, même si la question de la distance là, n'a pas du tout été réglée. Par exemple, les SCS qui étaient menacés de fermeture, ben, ne le sont plus pour l'instant. Ils sont soutenus pour une transition. Et on a également réussi à faire en sorte qu'il y ait une responsabilité du plan de cohabitation qui soit porté par Santé Québec et non plus sur les épaules des groupes communautaires. Ce qu'on retient en fait de cette démarche-là, c'est vraiment que l'action collective porte fruit. On a mis en commun nos ressources et ça a été un facteur vraiment gagnant. Ça a été une force pour nous de mener avec vraiment souplesse et flexibilité parce qu'on a créé des espaces qui ont permis les stratégies multiples, diversifiées, tout en restant unis sous le chapeau de la coalition. Et on retient aussi que la réduction des méfaits en tant que solution dans nos communautés doit rester vraiment au cœur de nos communications parce que c'était clair pour nous que le public a encore besoin de bien comprendre cette information-là pour être un allié avec nous.
Thank you. Thank you, Sandhya, for your vital work. And there's a lot of lessons that the rest of the country can take as far as mobilizing collectively and engaging with the legislative process. Thank you so much. Our next panelist is Corey Ranger. Corey is a registered nurse with extensive experience in street outreach, community, and public health nursing. Corey is focused on harm reduction since 2013 in both Alberta and British Columbia. Currently, Corey is the clinical director at AVI Health and Community Services, a board of director at the Canadian Drug Policy Coalition, and a research and communications intern with the International Drug Policy Consortium. Thank you, Corey, for joining us today.
Thanks for having me.
We know that drug consumption patterns have shifted significantly in Canada, and that often supervised consumption services have not been able or not authorized to adapt their services to people's evolving needs. How are groups working to scale up inhalation services in BC, and why is it so important? What are the results and lessons learned?
Yeah, thank you. I want to start off just by giving a shout out to researcher Kate Salters at the BC Center for Excellence in HIV/AIDS Care because she helped me do my homework for this. As of October 2025, the BC Centre for Disease Control reported 39 OPSs or SCSs in BC with witnessed consumption, but only about 23 with witnessed inhalation, meaning fewer than 2/3 of the sites are equipped to support the route of consumption. That now accounts for most deaths in British Columbia. BC Coroner Services reports that about 64% of unregulated drug deaths now involve smoking, compared to about 10% for injection. And we've known this trend for a really long time. Smoking deaths have more than doubled since 2016, when they accounted for only 29% of deaths. Instead of scaling up inhalation services in response to this reality, we're actually in a period of policy regression. Expansion has plateaued, new sites have been paused, particularly ones that were planned within hospitals, and political attention has shifted towards the false binary of recovery versus harm reduction. This regression has been driven by a coordinated attack across Canada on harm reduction, rooted in mis and disinformation, and in particular relevance to supervised inhalation services, relating to false claims about the harms of secondhand fentanyl exposure. Despite the absence of evidence, this moral panic has shaped policy, labor relations, community opposition, and even BC's return to recriminalization. Rather than correcting misinformation, policymakers have largely accommodated it. Inhalation services, because they're visible, have become politically expendable, even though they reduce deaths, public drug use, and all of the benefits that we know the evidence shows. The closure of the Thomas Donaghy OPS in January 2026 is a really clear example of how access can disappear overnight, not because the need changed, but because political and property pressure were allowed to win. There's been some really important statements that have come out of some high-ranking officials, including both the Office of the BC Human Rights Commissioner and the Office of the Auditor General in British Columbia, who have said the same thing. Inhalation services have not kept pace with demand. Guidance is outdated, access is geographically inequitable, and this gap increases the risk of injury and death, especially in rural and remote communities. The Supervised Inhalation Cohort Study, or CISCO, launched in 2025 to ask a simple question: how are supervised consumption sites meeting the needs of people who smoke drugs? And with over 300 interviews completed so far, early results show high satisfaction with existing sites and clear room for improvement, especially related to scaling up more access to smoking-specific harm reduction. So I want to say, this is a very bleak picture, obviously. But it's also not an unsolvable problem. We actually know how to do safer inhalation services well in BC. We have the evidence, we have the operational experience, we have the workforce. What's missing is political follow-through and courage. Policy regression doesn't have to be permanent, but if we stay silent on it, it will be. We need to hold our governments and these moral entrepreneurs who have been perpetuating mis and disinformation accountable, and recenter the humanity of people who use drugs, and stop letting fear over things like funding keep us quiet. If we want real change, we need structures and solidarity that aren't hostage to 2-year funding cycles. I think that this is something that we can accomplish, but we really need to change our approach. Thank you.
Thank you so much, Corey. So key to talk about inhalation services, and it's so frustrating when the regulatory model doesn't allow for what people need to keep their bodies safe, and can certainly see some common threads emerging as far as the state of harm reduction throughout the country. Thank you, Corey. Our next panelist is Marina Klassen. Marina is a community organizer and harm reductionist, a Master's of Social Work student at York, and has been working professionally in harm reduction, program coordination, and case management for a decade. They helped found and currently organize with Harm Reduction Advocacy Collective Toronto, a grassroots community collective of people who use drugs and their comrades, frontline workers, and loved ones who are fighting for healthcare equality, the protection of harm reduction infrastructure in Toronto, and full drug user liberation. Thank you so much, Marina, for joining us today.
Thank you so much, Peta, for that introduction. And I just want to thank everybody here on the call for being here and all the important work that you're doing here. It means so much to see this, and it's really hopeful and encouraging. As Beta said, my name is Marina. I'm one of the organizers with the Harm Reduction Advocacy Collective. Just a bit of context. First off, we actually formed in response to the fight to protect harm reduction, the fight for drug user liberation. And we formed because we were seeing the tide coming, the resurgence of an anti-drug user and anti-harm reduction sentiment being seen in policy, and being seen in community, and being seen in right-wing media, and among right-wing politicians, and among those who are profiting off of the toxic drug crisis. We were noticing those trends, and we recognized that we needed to create a space that was accessible, welcoming, and supportive to each other in our leadership development to sustain the harm reduction movement in Toronto. And also be in solidarity with those across Turtle Island that are facing similar challenges. So when we kicked off, we actually was prior to the passing of Bill 223, but we really grew in our momentum and our mobilization in response to the defunding of our sites, 11 closed SESs and 4 UPHN sites, shelter sites closed in Ontario so far. And then the passing of Bill 223, of course, which has led to many harms, which Jillian and Sandra were able to outline for you. I just wanted to emphasize that the purpose of a group like HRAC is that we're led by drug users, but we're in coalition with both frontline workers, harm reduction workers, social service workers, and people that love people that use drugs, and people that are allies to the harm reduction movement. So the emphasis is on coalition building. And I think that that's really part of the way that we mobilize and fight, is build broad-based coalitions and come from many perspectives in order to build power. We are both we mentor and build political consciousness and organizing skills. We do direct action and protest and advocacy. We do mutual aid and care networks. And then, of course, we mobilize to resist the dismantling of harm reduction healthcare and the harm reduction movement itself. I just think it's really important to ground, and this is something that our collective really tries to focus on, is the fact that harm reduction actually never really belonged to the state in the first place. It never really belonged to public health in the first place. It never really belonged to the medical addiction services in the first place. Harm reduction is a movement by people who use drugs, by those that are criminalized. It is rooted in marginalized communities' teachings, and I just want to refer back to Shira Hassan, that it's a movement built in abundance, love, and joy, and finding survival. And it is founded actually originally on principles that were by Black, Indigenous, and racialized people, queer and trans folks, people that use drugs, and sex workers. So it's a movement that is actually deeply about how do we survive and take care of each other when the state itself, the government, has actually neglected us, because that's the way that these communities have been continuing to exist and survive this whole time. So even though we're fighting for, yes, these public health care things to come back, we also need to get grounded in the fact that the state is not going to save us. And we can see that right now. But the state can be our ally at times to help if we need to mobilize to get things in place, and the medical system can be our ally at times. But ultimately, Even in all of our grief and loss, who do we come back to? We come back to watching out for each other. So, how can people support this movement? So, and support people that use drugs in this movement. So, first of all, you can join our movement. Help us get organized. We really need to out organize the right wing. I think that we're in a really conservative time politically, globally, nationally, and locally. And in order to win back our healthcare and human rights, it takes a really strong, large, well-coordinated movement. If you are a person who has lived or living experience, if you're a person who loves someone who uses drugs, if you're a person who's a frontline worker, if you're an ally to the movement, come and join us. And when I say us, I mean also come and join Harm Reduction Advocacy Collective. We meet every single week Tuesday. And we meet at College Street United Church, and we would love for you to join us there. You can follow our Instagram to find out about those meetings. And I'm going to ask them to put our Instagram in the chat. I'm going to ask them to put also our email in the chat to reach out to us. But I also want to say that you can also start your own collective. You do not need to wait on anyone. Any drug user-led movement has popped up because of the initiatives of people taking forward and making things happen for themselves. So if you're not here in Toronto, you can start your movement where you are. And I know that that's already happening and taking place, and we're in solidarity with all of those movements across Canada. Secondly, I think you can support by being an ally. So I'm especially right now speaking to those that have maybe some more privilege and access than some of us that might be more marginalized. If you have the ability to speak out and support publicly in deputations, in town halls, to your representatives, to the media, to knock on doors, to get into difficult conversations with your neighbors. I think that it's really important that we start talking to each other about the importance of the life-saving work that happens in safe consumption sites and in harm reduction programming, and that we start really, really building strong, strong neighborhood communities that recognize and watch out for each other. So that benefit, because we know that this benefits the entire community. Harm reduction does not just keep people that use drugs safe, it keeps the entire community safer. Help us demystify it. Help us get rid of the fears that people are actually putting out there. It was right-wing mobilizing and hate propaganda that the Ontario Ford government used to justify the closure of safe consumption sites. But it could be you going out in your community and actually talking about mobilizing for love and for compassion and for non-judgmental care. It could be you going and getting out there and showing your support. So we need allies really badly right now. And we're feeling quite lonely, to be honest. We're feeling quite lonely. And I think that I would really like to see more people speaking up that have a lot more privilege. And I'm also speaking to the medical community there with that as well, not just everyday citizens. So I think there's also third, I don't know how I'm doing on time. I hope I'm okay, but everyday community support. I think that there's an important role, especially again for allies, to be kind to our houseless neighbors and people using drugs in public. They're not using there or living on the street because they cannot, because they're not, they're choosing to. It's because they are forced to. So if you call the cops on people, you're actually putting them in a worse situation, and we need you to learn how to show up and care in different ways. Learn how to respond to an overdose. Use another type of crisis support, like the 211 crisis line we have in Toronto. There are other ways to show care. And then lastly, I'm just going to say that we recently had a really huge loss of the West End Parkdale safe consumption site. It was a really devastating blow to our communities. And in that, it also became clear that it was a wake-up call that there's been a federal shift away from harm reduction support. And it's not just Ontario for government that is not supporting us. It's actually all three levels of government that are not showing up for us. And so why can't we have OPSs like BC that don't require this political block here? Why can't we have exemptions? So I encourage you to go to our link tree, which I hope someone will drop in the chat, to be able to write an email template to all levels of government. And lastly, if you can donate and support to all grassroots drug user groups, things like Drug User Liberation Front in BC, Toronto Indigenous Harm Reduction in Toronto, and you can, if you want to, donate to us, HRAC at our GoFundMe, which we can also drop in the chat to the link. Thank you. I'm sorry I went over time. Mwah.
Thank you, Marina. All of that was so key, and especially appreciate you highlighting really clear, concrete ways to get involved, which is something that we want to get into on this panel. And also for highlighting that harm reduction exists outside of the state, and what does it mean when we are sitting at this really interesting intersection. Really appreciate all the incredible work that you're doing here in Toronto. We'll move on to our last panelist, Robin, and also a note for the audience. There is a Q&A box at the bottom, so feel free to submit your questions, and we will be taking questions from the audience soon. MPP Robin Lennox is the official opposition's shadow minister for mental health and addictions and primary care. Robin is a family physician in Hamilton and an advocate for public health. Through her work with St. Joseph's Hospital, HamSmart, and the Shelter Health Network, she has provided frontline care to the unhoused community and to combat the overdose crisis. Robin served on the City of Hamilton's Public Health Subcommittee and is committed to building an Ontario where everyone can find a home, access world-class healthcare, and afford a good life. Thank you, MPP Lennox, for joining the panel today. Drawing from your unique experience, both as a former medical director of a supervised consumption site and a political representative now, what recommendations do you have for how to engage policymakers? And is there anything that you have learned as a political representative that you wish you could have known in your former role?
Thank you, Bita, and thank you so much to the other speakers. I completely admire all the work that you're doing, and I thank you for doing it. It's such an interesting question because actually the decision to enter into political life really hinged actually when sort of in the summer in 2024, the announcements started coming out about the closures of the supervised consumption sites, and I'd been involved in the first OPS that opened up in Hamilton, and then one of the second urgent public health needs sites as well here. And it was just sort of my breaking straw was seeing services that had been built with tremendous community input and work and care. And then, 7 years later, sort of have all of that work sort of undone at the whim of a politician who'd probably never stepped into a supervised consumption site. And so it was really a big fuel for me to try to get more involved because I really wanted to see changes in policy. And I think it also kind of happened at a time when, I was trying to advance, some proposals around harm reduction, around sort of expanding access to care for people who use drugs in Hamilton, where I practiced. And, finding that, we could put together, our teams could put together the best evidence case, the best business case, and yet still we were not somehow able to break through to be able to see these programs and these policies realized. And sort of trying to figure out, okay, what was existing in that gap? Because I think, perhaps coming from a healthcare background or a medical background, you have this idea of, okay, if we generate enough evidence, if we do the research, if we make the financial case that this is going to save our health system money, then surely, people will be able to see reason and implement those programs. And unfortunately, that is not the case when it comes to political decision making. And I know everyone, I'm sure, in this forum has realized that as well. And so I'd say the way that I would advise to advocate, I think there's sort of that inside organizing and the outside organizing, and I think both are really important, but the weight of each is different based on what kind of government you're working with. I think in Ontario right now, we have a majority conservative government who has made their position on harm reduction and supervised consumption sites extraordinarily clear. I think it's still a feasible option to try to meet with those government members to sort of, give them the information, share some perspective. I'd say probably leading with like human stories is more impactful than the evidence in the business case at this point. But I do think that the inside organizers is going to be a little bit more limited in the current context that we have in Ontario because the government is so dug in on this policy. I really truly think that the way to go is by trying to do that mass public organizing and try to out-organize those who are trying to close the sites. Because those who are trying to close the sites are really, really well organized right now. They are sending tons of emails, they are advocating to their representatives, they are calling, they are making themselves extremely loud. And I think we, on the side of those who are in support of harm reduction, need to be just as loud or louder in support. And that means, really, I think over this next year, sort of rallying around the remaining sites whose exemptions are going to be coming due. Because like everyone highlighted sort of previously to me who spoke, this is not about the 200 meters. It never was. Right? The 200 meters was a really nice way to make it sort of about the kids. But it's a strategy to close the sites. And the part that's making it more challenging is the fact that the ministry can block municipalities from seeking the exemption. That's where we're going to see the other sites most vulnerable. And so, of the 12 sites that are currently still existing in Ontario, I believe about 8 of them are going to have their exemptions come due within the year of 2026. So there's a lot of work that we could do to try to organize around those sites as their exemptions are coming due, to try to make us as loud as possible to say, like, we want this site to continue, and I think we need to build unlikely coalitions. So there are so many fires going off right now, just speaking about Ontario, but of course across the country as well, that we all can become very, very siloed in our area of organizing, but we need to start coalition building across areas of organizing. So, we need to start connecting because the same people who are making drastic cuts to education, who are, making drastic cuts to the funding of our hospitals, who are, tearing down environmental legislation, it's the same government doing all of that, right? And so we need to sort of reach out to those other folks who are organizing, for our schools, environmental groups, harm reduction groups, and bring our efforts together and say, like, we're going to show up for your organizing and you can show up for ours. And together our voices are going to be louder than if we're all organizing in our sort of own little lanes. So we need to start building those coalitions. And we need to start talking to people. I think one of the things about the current world that we're in and, maybe feeling a little bit more disconnected online is I think we've stopped recognizing that we are the most influential in our own social networks. So among the people you work with, your friends, your roommates, your colleagues, students in your class, those are the folks who know you and are going to trust you. So I think we need to start talking politics again, like it's dinner conversation, to start, making connections between what we're seeing in real life and the political decisions that are influencing that. And around this conversation specifically, I think if we root that conversation in the impact on community safety was sort of weaponized to close the sites. But I think we need to talk about supervised consumption sites as a community safety measure, and how the absence of those sites is making our communities less safe for everybody, less safe for people who use drugs, less safe for everybody else too. And so we need to sort of use that to craft our arguments in the same language that's being used against us. I'll leave it there because I think I'm out of time, but happy to take any questions.
Thank you so much, Robin. All of the panelists have the difficult task of answering very big questions in very small sound bites. So my sympathies. But before we turn it to the public Q&A, because there are some really great questions in there, for any of our panelists, do you have any concrete opportunities for people to get involved in your provinces in this work that you can share, or perhaps even drop some links in the chat? And I love this conversation about unlikely alliances. I'm curious if there are any examples of unlikely alliances that you have participated in this work that maybe we can learn from and adapt to build that broader base of support. Yeah, Marina.
Yeah, thank you so much, Robin. I really liked what you were saying there. Unlikely alliances is a big thing. I think we need to be thinking about in coalition building. Some things that HRAC has done has been that we have tried to do kind of unlikely alliances that are coalition building with like other anti-Ford government conservative movements, even the bike movement, the environmental movement, working with drop-in networks, the social housing justice network, encampment justice groups, no policing in schools, housing justice groups, so tenant rights, like around Bill 60. We actually had a speaker at the Bill 60 rally that came and talked about the harm reduction issues we were facing, and particularly that was that Bill 60 passed the same day that it was the closure of the Parkdale SES. So it was a really significant moment. Library Workers for SES is a group, Moms Stop the Harm, and there are now all these like parent groups actually and neighborhood groups that are showing up actually in support of harm reduction in response to the anti-harm reduction sentiment. So there are actually these large swaths of really great neighborhood groups. I'm going to shout out Parkdale. There's a neighborhood group that's been supporting, and Leslieville. And then lastly, I just wanted to say that April 1st is a pretty significant date. We're coming up on a 1 year anniversary of Bill 223 going into effect. And even though we know that that's not technically the reason that closed everything down, I think that if we mark the day that the site's closed officially, and we're defunded and we're forced to close, and the end of SOS funding, the halting of decriminalization processes, the halting of municipal funding, that's a potential rallying point. So I think that we should think about organizing a larger coalition with partnerships that can respond on that day in a big way that's public.
Thank you, Marina. Corey.
Yeah, I'll be quick. And I think this might also answer Jasmina's question in the chat as well. And, I would almost even push back against the term unlikely alliances, because there is a lot of common ground and there is a lot of shared root causes in some of the struggles that we're seeing out there. And so I think when we start to see that common ground, and we show up for other movements as well, that we're going to see more of a groundswell of a response. And, some of the examples include there's some really great publications that have come up that have shown the links between climate justice and drug policy, right? And similarly, some of the narratives that are being employed, I can't remember which panelist said it, but like the think of the children narrative has been extremely exhaustively utilized in anti-trans movements as well. And we need to show up for the trans community now more than ever as well. And so I think that there is a lot of common ground, and that there is a lot of opportunity for us to grow the movement. And just a little plug here, June 26th is International Support Don't Punish Day. And so that might be a really great opportunity for us to come together one more time and push back together.
Thank you, Corey. We'll also bring back Sandra and Jillian to the panel. And first we'll go to Sandia and then Sandra.
Merci. Alors, de notre côté, je voulais également parler de d'alliances qui ne sont pas nécessairement inattendues, mais plutôt inhabituelles, justement. Parce que, outre toutes celles qui ont été nommées et pour lesquelles, en fait, je pense qu'on fait certaines démarches déjà depuis quelques années, mais on a aussi à aller un peu plus fortement vers les autres secteurs comme l'environnement, comme les droits des personnes en situation d'itinérance, etc., d'aller largement. Mais on a également fait des démarches dans les dernières années auprès de différents ministères. Donc, pas seulement le ministère de la Santé et des Services sociaux au Québec, mais aller voir également le ministère de la Sécurité publique, le ministère de la Justice et les entraîner, en fait, dans notre discussion, dans nos conversations sur les fondements de la réduction des méfaits et l'importance des politiques qui sont en cohérence avec ces fondements. Donc, je pense que c'est un aspect que j'avais envie d'ajouter également dans cette question-là des alliances inhabituelles.
Thank you, Sandhya. We'll go to Sandra next.
Yes, I'll be fast. I just wanted to say I would want to touch on, I wouldn't say they're likely alliances, I'd say they're necessary alliances because none of the people we work with have Occupy, like they're all intersecting. The many sex workers I work with are also people who use drugs, and similarly, the people living with HIV or hepatitis C, they might be migrant workers or migrant people. So I don't think we can do any of this work in isolation simply because none of these communities that we love and hold dear are isolated from one another. So I mean, that's how we're expanding our migrant justice work because we know that migrant workers obviously are affected by regressive drug policy and the many communities we work with. So I don't want to call it a likely alliance. I think it's a necessary alliance. We all need to think intersectionally.
Thank you, Sandra. Lots of great questions in the chat, including requests for information to volunteer. So if there are links that people can drop in the chat, please go for it. There is a question specifically around the government and the granting of exemptions, and particularly in Ontario, this question where I believe the asker of the question is based. So, for example, waiting until the last minute, granting shorter length exemptions, and also asking health centers to meet really onerous or ridiculous requirements, such as dealing with loitering and getting sign-offs and endorsements from police. So this question was for Robin. Is there a role the Ontario opposition parties can play in calling out the feds for de facto walking back their support? And if other panelists also want to chime in on this, you're welcome. But first, we'll go to Robin.
Thanks. Yeah, I think it's always interesting. I think primarily because we're sort of a provincial party, primarily we try to stick within our sort of provincial advocacy, but to have that when there are intersection points between sort of federal and provincial issues, often what we'll do is we'll reach out to our federal counterparts in the federal NDP to say, like, how can we hold both levels of governments accountable? How can our advocacy efforts be sort of paired so that they're like we're working on the same messaging, essentially? So on this issue, absolutely, we need to be doing that to make sure that not only are we sort of advocating in terms of the Ontario government's role, but that we're making sure that those dual levels of barriers are not being put onto the local organizations when they're trying to get their exemptions passed.
Thank you for that. Oh yes, Sandra, go ahead.
I just wanted to expand a little bit on that. I mentioned it earlier in my presentation that there is this case brought by an individual, a private citizen, who felt that the consultation process for a supervised consumption site was inadequate. And I think this has ripple effects across the country. Health Canada is obviously influenced by a lawsuit against it or a judicial review of its exemption application. So I think we could also, like, it's important to mobilize against and to ask Health Canada to show more leadership. But I think in some ways, the outcome of this litigation could also have very could influence practice across the country. And so we want to show our support to our friends in Ottawa who are resisting this judicial review.
Thank you, Sandra. We'll continue on with a question from Bruna. While the statistics on the deaths should already be enough information, people and organizations who are fighting against SCS and other harm reduction services most of the time don't really care about the data. What other evidence can we bring? So, for example, maybe the economic impact, the rates of infectious disease transmission, impacts to our emergency services, et cetera, or maybe other lens and angles that we haven't named yet. Any of the panelists want to speak on these other kinds of information that we could bring into advocacy efforts? Jillian, go ahead.
Yeah, I think that Robin said something in her comments that really struck me as a researcher who I'm not naive enough to think that the evidence always matters. And I'm not naive enough to think that when we talk about evidence-based policymaking or evidence-based healthcare services, that it means that we're always foregrounding the evidence, because I think we've seen the ways in which stigma and discrimination really, really do actually mean that we put aside oftentimes some of our best available evidence in order to stick with in that, moralistic judgment place. I've done a lot of research around economic impacts of supervised consumption sites. We have, 30, 40 years of evidence around the impacts that distribution of sterile injection equipment, harm reduction equipment, all of those things, the impacts they have on reducing bloodborne infection transmission. We know that smoking equipment distribution brings a group of people, Corey pointed out, a group of people who oftentimes we've been very slow to change our harm reduction services to be adapted to the needs of people who smoke drugs. Those are under increasing threat. I think right now we need to call attention to the fact that we're not having a crisis of evidence. We're having a crisis of empathy. We're having a crisis of an inability to actually really, really center the needs of some of our most vulnerable community members. And I think we also have to be open about the fact that right now it's very easy to lean into stigmatization of people who use drugs by all levels of government and by some of the forces who are organizing against these services, because that's easier than building affordable housing. That's easier than fixing the destruction of our healthcare system that's happening right in front of our eyes. Our government currently doesn't care about increased wait times in emergency departments because they're currently in a process of dismantling our public healthcare system so we can move towards privately delivered healthcare options. So I think we have to be really, really clear of what's actually going on right now. This is one little bit of much larger challenges, and we need to actually recenter care and concern, because we can do difficult things like building housing and providing proper care, but we actually have to really, really focus on centering our empathy and the ways in which we can go about supporting community members.
Thank you, Jillian. Just a few minutes left in our discussion today, but we'll go Sandia, Corey, Marina, and hopefully Rob will have time also for Robin. Go ahead, Sandia.
Merci. Alors, mon intervention allait dans le même sens de tout ce qui vient d'être dit de façon très éloquente par ma collègue Gillian. Donc, merci beaucoup. Alors, je vais éviter de répéter, mais par contre, j'ajouterais un volet qui est quand même cher à mon cœur, parce que c'est le volet de diminuer la stigmatisation. Alors, pour moi, c'est une des raisons pour lesquelles on ne parle jamais de services de sites de consommation supervisée, mais bien de services de consommation supervisée, parce que c'est un service qui s'intègre dans un milieu où là, il y a plein de choses qui se passent. Et ce milieu, c'est un milieu qui est humain et qui offre différentes possibilités pour que les personnes puissent à la fois prendre soin d'elles, mais également s'épanouir. Donc, ce n'est pas un focus unique sur l'usage de substances, et c'est pour nous quelque chose d'important aussi à mettre de l'avant dans le discours, pas seulement justement les données probantes. Cette façon de faire fait aussi en sorte que la voix des personnes qui sont présentes dans les centres de réduction des méfaits est totalement incluse, et cette voix-là, elle est puissante, elle est diversifiée et elle apporte un regard complètement différent sur qu'est-ce qui se passe dans ces centres de réduction des méfaits et ça a un impact important sur l'écoute qu'on a dans la population.
Thank you so much, Sandhya. Over to Corey.
Okay, I'll try to be quick and I'll try to string these loose collection of thoughts together at the end. I think I've spent maybe the last 10 years doing rounds of community engagement and consultation related to supervised consumption services, including in Southern Alberta, which is not a great place to do community engagement on supervised consumption services. And evidence is helpful, but you have to understand the motivations of the opposition as well. And if so, does it work? Doesn't it work? Sometimes isn't the appropriate framing. Doing things like narrative storytelling, futures thinking, scenario building are helpful ways to try to bridge connections, finding common ground with folks. I hear people all the time like, oh, there's so many people outside on Pandora. And, instead of saying like you're being a dehumanizing jerk, what I will say is like, yeah, it worries me too. This is really scary. Let's talk about how we can make everybody safe. Let's talk about how we can get people housed and trying to bridge those connections. And the last thing I want to say is there's a time of immense crisis right now. People are struggling. It's really, really awful what we're seeing on the streets, especially with the drug supply changing the way that it is. And so people are walking around with collective distress. And when we are feeling this kind of undefined distress, moral entrepreneurs will insert a narrative. They'll tell people how to feel about it. And so we need to spend more time on them and really pushing back against them and holding them accountable for the way that they're gearing people up and pushing them towards a hate-filled approach. Because when there's information vacuums, people seek answers, and the answers are being filled up by, the National Post and other post media columnists.
Thank you, Corey. Over to Marina next.
I'll try to be brief. I know everyone has said, some of the main points, but I just wanted to reflect back, Cynthia and Jillian, like recentering that this is about control. This is actually not about the safety issues in our communities. It's a smokescreen. It's meant to dismantle our public healthcare system. It's meant to target our most vulnerable. And I think that the media is not quite getting that. And I think that the public consciousness is not quite getting that full message. And so I'm trying to figure out, how do we clearly communicate that? How do we build that critical consciousness and help people understand harm reduction on a basic level, not as just needle distribution, safe consumption sites, but as like a principle and a practice and a way of being in the world that's rooted in love. And so I think there's a very different thing. There's a hate versus love thing going on here. And it's possible that if you can make that messaging more clear, that you can build more people in so your movement is larger and stronger. And I just think we need to we need to start speaking to each other more and less at the state, as Robin said. Like we need to start speaking to each other. So I hope we can continue this conversation later. Thank you.
Thank you so much. A lot of really excellent threads here. Appreciate you all so much. We'll give about 20 seconds to Robin and then over to Janet for closing.
Perfect. Yeah, thank you. I agree with everything the other speakers said, building common ground, talking to each other. The other thing I would say is at a certain point, and I can say I'll be the political part, but at a certain point, we just need to change the people making the policy decisions to order to change the policies. And it doesn't totally matter if someone goes to vote because of harm reduction or because they don't like their healthcare or because, we just need to help people. So I think that's where those conversations are important in terms of connecting the dots. The same people who are harming people who use drugs are the same people who are harming people on social assistance, the same people who are harming students in schools, the same people who are, neglecting kids with special needs. I think we need to, keep pointing at the policymakers, and whether it's your ballot issue or not, getting people to actually participate and pay attention to the political process is a huge piece of changing the policies.
Thank you. Thank you all so much. Thank you all for your labor and for everything that you do to support people who use drugs. Many, many thanks. I'll pass it over to Janet.
Hello, everyone. My name's Janet Butler-McPhee, and I have the good fortune to work alongside Sandra at the Legal Network as the other co-executive director. Je veux dire merci beaucoup d'avoir passé du temps avec nous aujourd'hui. Nous savons qu'il s'agit d'une question importante pour de nombreuses personnes. Thank you so much to our panelists. Thank you so much to everyone who took the time to join us today. Personally, I always find in times of great challenges, the humanity, compassion, and real examples of community care that we witness in this space give me hope for something better. We hope you'll keep in touch with us by visiting hivlegalnetwork.ca and joining our bilingual newsletter. We also have to thank the Public Health Agency of Canada for providing the funding that enable us to host today's webinar. So maybe, as Marina has mentioned, a bit of allyship is always welcome in whatever form it comes. We'll be sending out a short email with some helpful links and ways to stay engaged, and we'd really appreciate it if you'd take the time to spend a few minutes responding to a really brief survey so that we can keep getting funding for this movement to try to bring these spaces so that we can gather. Thank you again, and please take good care of yourself and your people.